Welcome back to Part 69 of Decode Healthcare with Harshal. I am absolutely thrilled to have you here for this coding exam masterclass. So, if you're gearing up for your AAPC or AHIMA exams, we're talking the CPC, the CCS, or the CIC, you already know that the official CMS ICD-10-CM guidelines are your ultimate rulebook. But, memorizing the rules and actually applying them flawlessly when the clock is ticking, those are two completely different things. Today, we're demystifying those high-yield guideline scenario traps that test writers absolutely love to use to trip you up. We're going to break down these minefields step by step so you can navigate them with total confidence.
Okay, let's dive into this. Here is our agenda, mapping out the 4 specific traps we'll conquer today. Inpatient versus outpatient rules, canceled procedure sequencing, combination code traps, and finally, 7th character extensions.
Starting right off with trap number 1, inpatient versus outpatient rules, the rule-out divergence.
Now, test writers will test your awareness of what setting your patient is in for sure. Why? Because the setting literally dictates how you handle uncertain diagnoses. Just look at this stark contrast here. In the inpatient setting, if a provider writes down a condition as rule out, probable, or suspected at the time of discharge, the CMS guidelines say go ahead and code that condition as if it's confirmed. But beware, if you take that exact same logic into an outpatient setting, you are going to fail that question. Outpatient coding strictly bans the coding of uncertain diagnoses. If it isn't definitively confirmed in a clinic or physician office, you just can't code it. Instead, you have to code the signs, the symptoms, or the abnormal test results that actually prompted the visit.
To really hammer this rule home for the outpatient setting, listen to this direct quote from the official outpatient guidelines. It explicitly says, "Do not code diagnoses documented as probable, suspected, questionable, rule out, or working diagnosis or other similar terms indicating uncertainty." Seriously, burn this into your memory right now. If the exam question says outpatient clinic and the doctor writes probable pneumonia, your answer absolutely must be the patient's symptoms, like a cough or fever, never the pneumonia code itself.
Moving on to trap 2, canceled procedure sequencing, when surgery stops.
This happens all the time, both in the real world and on your certification exams. A patient is all prepped for surgery, but then a sudden complication forces a complete cancellation. Let's test your active recall with a quick clinical scenario. Imagine a patient is admitted for a knee replacement due to osteoarthritis. But right before surgery, their blood pressure spikes. They're diagnosed with acute hypertension, and the surgery is called off. So what gets sequenced first on this claim? Is it the complication, the reason for the surgery, the cancellation code? Take a second and really think about it.
So, the crucial point here is this strict 3-step sequencing staircase mandated by CMS guidelines. First up, you must always sequence the underlying reason for the surgery as your primary diagnosis. This is the whole reason they came in. Second, you sequence the complication that actually caused the cancellation. And third, you bring up the rear with the appropriate Z53 code. That's the code that officially tells the pair, hey, this procedure, it wasn't done.
Let's map our knee replacement question directly to these exact codes so you can see how this staircase works in practice. Even though the surgery didn't even happen, M17.9 for the osteoarthritis leads the claim. It's followed by I10 for the hypertension, that's the complication that derailed everything. And finally, we tag along Z53.09, procedure not done because of a contraindication. Listen, if you sequence that hypertension first on your exam, you've fallen into a trap and you'll get it wrong. The reason for the surgery always leads.
Trap 3, combination code traps, mandatory stacking.
Okay, so test writers love, and I mean love, giving you scenarios where a patient has multiple related conditions. They are trying to tempt you to code them all individually. But remember, a combination code is defined as a single code used to classify 2 diagnoses or a diagnosis with an associated secondary process or complication. When the ICD-10-CM index hands you a combination code that fully identifies the patient's conditions, you are legally bound by the guidelines to use it. You absolutely cannot dual code those conditions separately if that combination code exists.
I want to highlight 3 massive, high-yield combination scenarios that will absolutely 100% show up on your exams. First, diabetes with manifestations. The E11 series links type 2 diabetes with complications like neuropathy or chronic kidney disease. Second, sepsis. When sepsis leads to severe sepsis and acute organ failure, you are looking at a mandatory 3-code stack. You sequence the underlying systemic infection first, followed by the specific R6522 code for severe sepsis second, and then the specific organ failure third. And finally, the acute myocardial infarction 28-day window. You absolutely must know when to use an I-21 code for an initial AMI versus an I-22 code for a subsequent AMI that happens within 4 weeks of the first one.
Let's look at a very specific example of mandatory stacking with diabetes and chronic kidney disease. Check out this claim. E11.22 represents type 2 diabetes with diabetic chronic kidney disease. That right there is your combination code. However, the guidelines mandate that this combo code must be paired with an additional code to identify the specific stage of the chronic kidney disease. So you literally must stack N18.4 for CKD stage 4 right behind it. Test writers are going to try to trick you by offering an answer with just E11.22, or by coding the diabetes and the CKD entirely separately without using the combo code at all. Don't fall for it. Always use the combination code and always check the tabular list for those use additional code instructions to make sure your stacking is complete.
And that brings us to Trap 4, the 7th character extension, A, D, and S.
This final hurdle focuses on injuries and external causes. Honestly, this is an area just notorious for widespread myths that end up costing examinees precious points. So let's aggressively debunk a massive myth right now. The myth is that the 7th character, A, stands for the patient's very first visit, and literally every single visit after that has to be a D. Well, that is completely false. The reality is that A means the patient is receiving active treatment for the condition. It doesn't matter if it's their first visit, their second, or their fifth. If the provider is actively treating that injury, say they are evaluating a new symptom, doing surgery, or aggressively managing it, it gets an A.
And this brilliantly illustrates the chronological patient care journey and exactly how you should apply these extensions. You start out with A for the initial encounter, which represents the active treatment phase. Once that active treatment is fully complete and the patient transitions into routine recovery and healing, then you switch over to D for subsequent encounter. Finally, if the patient develops a complication or a late effect that pops up as a direct result of the original injury long after it's healed, you use S for sequela.
Let's break this down into some really specific, testable scenarios. If a patient gets ER treatment for a fracture, that is an A. If they go see a brand new doctor the very next week, but they are still receiving active care for that fracture, well, it is still an A. Do not let the fact that it's visit number 2 fool you into using a D. Now, if they come in for a routine cast removal during the healing phase, so no active intervention, just routine recovery, that is when you finally assign the D. Lastly, for an S, imagine a scar forming after a burn. The scar is the sequela. Remember, when you're using S, the specific type of sequela, the scar, is sequenced first, followed by the original injury code, the burn, with the S extension attached to tell the story of exactly where that scar came from.
Wow, we have covered some intense ground today. Dodging these high-yield guideline scenario traps will drastically improve your performance on your CPC, CCS, or CIC exams. But hey, the learning never stops. I want to leave you with a bit of a provocative question to ponder before our next masterclass. When a patient has cancer that is metastasized, which one comes first on the claim? The primary neoplasm or the secondary site? Think about it, because in Part 70 we are diving deep into Chapter 2, Neoplasm Coding Guidelines and the fierce sequencing rules that govern them. Make sure you like, subscribe, and hit that notification bell so you don't miss it. Keep studying those guidelines, always trust your tabular list, and I'll see you in the next explainer.